In this lecture, we're going to be doing sinus dysrhythmias. This is Ginger Keene. And when we discuss interventions, it's important to keep in mind that each of you is required to work within the scope of your job description. We will generalize in this course in the following way: how monitor techs will generally assume the responsibility for identifying changes in a rhythm and notifying the nurse or other responsible clinicians. And nurses will generally be assumed to be responsible for recognizing changes in rhythm and evaluating the patient and initiating appropriate interventions. So the objectives for this content is identifying or describe the EKG characteristics of a sinus beat, the characteristics of dysrhythmias that originate in the SA node, the determinants of cardiac output, determinants of clinical significance of the cardiac dysrhythmia, the hemodynamic consequences of a sinus dysrhythmia, and the clinical management. So we're going to evaluate the patient and determine the clinical impact of any dysrhythmia, and we're going to learn how to manage these patients, especially with bradycardia. But we're primarily going to focus on the naming the sinus dysrhythmia, and they should be easy, and how it impacts on that dysrhythmia. So with the patient concepts, understand that when you're looking at an ECG, you're only looking at electrical activity of the heart. We cannot see mechanical activity. We would actually have to feel it, and we monitor the mechanical activity or the cardiac output by feeling a pulse, and that is what you would need to do. Any dysrhythmia is significant as it affects the cardiac output. So everything we do for cardiac patients is based on optimizing cardiac output. So stroke volume times heart rate, and stroke volume is the amount of blood ejected with each contraction. So stroke volume times heart rate equals cardiac output. And the normal cardiac output is between 4 to 8 liters. Obviously, we don't have a measurement for cardiac output in every patient. We need to evaluate adequacy of cardiac output in other ways. So thinking of what kind of symptoms would show a decrease in cardiac output. So increased heart rate or decreased heart rate can cause a decreased cardiac output, decreased blood pressure, increased respiratory rate, patients who are pale, cold, clammy skin. Cyanosis usually will be a later change. Changes in mental status, whether dizziness, confusion, lower level of consciousness, decreased urine output. It's a compensatory mechanism that your kidneys will hold on to water if there's a decrease in blood pressure. Pulmonary crackles, so if you don't have good forward flow or good cardiac output, you'll have a backup of blood into the lungs, and it'll cause leaking of fluid around the lung tissue. And chest pain, so if your coronary arteries are not perfusing well, then you will have coronary myocardial ischemia and coronary artery pain, so you will develop chest pain with those. I like to use the acronym VOMIT, especially for new nurses who are unsure of what to do in the face of emergency. So take a breath. Usually people want to vomit, but think about what you have to get done. So V for vital signs, take a set of vital signs, determine if they're hypotensive, what their heart rate is, respiratory rate and temperature if needed. And then O for oxygen, are they breathing adequately? Are they breathing at all? What is their saturation O2, and are they on oxygen, and what kind of O2 delivery system do they have? Monitor for M. So if they're not on an ECG monitor, you might want to put them on an ECG monitor, and also get a 12-lead EKG. I is for IV access, is it patent? And what kind of IV fluids are going through that IV? It's important to know, if it's something that if they're given an order for a bolus, you want to make sure there's no medication in that IV fluid. And then there's treatment. Think about what treatment is going to be needed for those patients who are unstable compared to stable. Okay, so let's do a checkpoint. Mrs. K is 72 years, retired teacher who comes into the ED complaining of feeling very lightheaded and dizzy. On assessment, her blood pressure is 82/50, heart rate is 42, respiratory rate is 24. She's pale and somewhat diaphoretic, You hear crackles in the bases of both lungs. She admits to feeling a little short of breath. She takes Acupryl and a water pill for high blood pressure. So would you say she's stable or unstable? And what would make you think that she would be either stable or unstable? Well, if you said unstable, you would be correct. And the clues that would support that decision would be the blood pressure being low, the change of mental status, we're feeling lightheaded and dizzy, diaphoretic, hearing crackles in the bases, and the slight shortness of breath. So these are all things that would determine that this patient is unstable. So you may hear these terms used interchangeable. Both people will use both terms, arrhythmia and dysrhythmia. Basically, they mean the same thing. And arrhythmia, by definition, is an irregularity in the rhythm, and dysrhythmia is the disturbance or dysfunction of the rhythm. So again, if we use these terms, they're both used in the same context. So now we're going to focus once again on rhythm analysis and add the next step, which is identifying the origin of the rhythm. So your cardiac rhythms, as we've discussed, originates in 4 sites. There's the sinus, there's the atria, there's the junction, and the ventricles. So we're going to focus on the sinus node. The sinus beat originates from the SA node. And whenever you have a rhythm that originates from the SA node, you're going to see a P wave that is upright and uniform. They all look the same. We usually see a P preceding each of the QRSs. So anytime you see a P wave, you can basically say sinus. So that rhythm is sinus, blah, blah, blah. So we are going to look at the different types of sinus beats. When we look at a sinus dysrhythmia, this is usually the result of a disturbance in the impulse formation, so automaticity. So whether the SA node is discharging too fast or too slow or just at an irregular rate, or sometimes it fails to discharge at all or conduct an impulse away from the SA node. So there's lots of different types of dysrhythmias. Automaticity, again, is one of the things that is regulated by the autonomic nervous system and determines if your sympathetics kicks in. If there's sympathetic stimulation, it causes an increase in your heart rate. It also increases the conduction through the AV node and increases myocardial contractility. So your sympathetic nervous system is the fight or flight, so increasing the heart rate and contractility, where parasympathetic is the resting and digesting, feeding and breathing, so it kicks in when you're mostly at rest. But also there may be sometimes a degree of stimulation of the parasympathetic through the vagus nerve, which causes a decrease in heart rate. So this will also decrease the conduction through the AV node and show a slight decrease in myocardial contractility. So normal sinus rhythm is the gold standard against all other rhythms. It is regular, its rate is 60 to 100. You have P waves showing that it came from the SA node, so it's sinus. Your PRI is normal, your QRS is normal, your QT is normal, and the causes, it's normal. It's what we all want our patients to be in, because it usually will give us adequate cardiac output. So there's not really a significance, it's a normal rhythm, and therefore any clinical management you would continue to monitor. Of course, we always have to make sure that we always treat our patients, not the monitors. So if you have a normal sinus rhythm, you always want to make sure that the patient is, there could be a patient that is pulseless with a normal sinus rhythm where they have electricity but no pulse. So always keep that in mind. We treat our patients, not the monitors. Sinus tach. Usually the stress of the body, will be reflected in a sinus tachycardia. So it's the normal body's physiological response to something going on. Normal response of the heart is when the body's demand for an increase in blood flow or oxygen, it's going to increase the heart rate. The SA node will gradually increase its rate in response to the needs of the body. Then when the decrease, then it will decrease after needs are met and begin to end It begins and ends usually pretty gradual. But in sinus tach, your rhythm is regular. Your rate's 100. Anytime you have any rhythm that's the heart rate's greater than 100, we put on the word tachycardia. So usually sinus tach is between 100, 160, usually not much more than 150. P waves are upright. They all look the same, identifying that the SA node was firing. Your PRI is normal, your QRS is normal, and your QT is normal, less than half the R to R interval. So when we look at the causes, it's a normal sympathetic response. It's a normal response to exercise or fever. It's a compensatory mechanism for hypoxia or hypovolemia. So if the body does not have enough oxygen or volume, it's going to increase the heart rate to compensate to make sure that it has adequate cardiac output. Also, pain and anxiety can be response to, and stimulants such as caffeine, alcohol, nicotine, and cocaine. So these are oftentimes in response to something going on in the body. So the clinical significance is the physiological response. And what it can do is it can increase myocardial oxygen requirements. Because if you have a persistent tachycardia, that causes a decrease in stroke volume because you have during a decrease in diastolic filling time. During diastole, when the heart's filling, if it's going too fast, it'll not have enough time to fill adequately. Also, during diastole is when your coronary arteries are being perfused. So if you have decreased that time of the filling, you're going to have a decrease of myocardial perfusion. So your coronary arteries are not perfusing your myocardium in adequate time. So eventually, especially in the elderly, they can sometimes find myocardial ischemia due to a tachycardia. The clinical management is usually benign in healthy people, but what we're looking to do is treat the underlying cause. So whenever you see a patient with sinus tachycardia, always ask why. In sinus Brady, your stroke volume, if it's adequate, so if you're adequately volumized, then bradycardia may be well tolerated, especially in many athletes. So they oftentimes have very strong hearts and great contractility where they can push around enough blood in 40 to 50 times as opposed to somebody who's in maybe normal sinus rhythm who pushes around enough blood in 70 times a minute. So their rate usually be between 40 to 60. Their P waves are upright. They're all the same shape because it's coming from the SA node. Your PRI is normal, your QRS is normal, and your QT is normal. So again, your demand for blood flow is usually tolerated very well, such as in sleeping also. So when you're asleep, your heart rate usually will go down because your parasympathetic kicks in at rest, and the patient does not feel any effects from the sinus bradycardia. Or if hypothermia is the fact, when extreme bradycardia is just maybe adequate to support the life. So there's sinus bradycardia. Again, you would assess whether the patient's stable or unstable. So normal variant in especially athletes, so it could be the cause. It's anything that increases parasympathetic tone or anything that decreases sympathetic tone, such as a vagal stimulation, so vomiting, valsalva, or suctioning. Also, an acute inferior wall MI can result in a bradycardia. So oftentimes, because the inferior wall of the left ventricle is supplied by the right coronary artery. The right coronary artery also supplies the SA node and the AV node of the conduction system, which, due to the infarction, myocardial infarction, can decrease the ability for the heart to go up and affect the SA node and AV node. Other things are digitalis or calcium channel blockers or beta blockers. These are examples of medications that can slow the heart rate a little bit too much if we're trying to maintain adequate cardiac output or decrease the ventricular rate because they're usually too fast or suppressing some kind of arrhythmias. And they're on these medications, so sometimes we have to monitor to make sure that the patients are not getting over-medicated. So the clinical significance is because heart rate times stroke volume equals cardiac output. So some people do not tolerate and will have a significant decrease in their cardiac output, and therefore they may be affected. However, if people are stable, you just want to determine the cause. They might be stable laying in bed, but once they stand up and get moving around and the body has more demand for more blood and oxygen, they may become lightheaded or hypotensive. However, but if they are unstable or symptomatic, where that shows the decreased cardiac output is now affecting their perfusion, then you would use the management of bradycardia algorithm. The management of patients with symptomatic bradycardia. So again, you're going to assess your patients for signs and symptoms of decreased cardiac output. Are they hypotensive? Are they short of breath? Do they have crackles? Are their skin pale, diaphoretic? So you want to make sure you put the IV O2 and monitor on. So therefore, and you will make sure that they have good IV access. So you would give them Atropine, 0.5 milligrams IV push. And if needed, you can start them on a dopamine or epinephrine drip, which dopamine would be 2 to 20 mics per kilogram per minute, and epinephrine is 2 to 10 mics per minute. And just to remind you that dopamine, you would want to weigh your dope. And if needed, you may have to do a possible transcutaneous pacing if the heart rate cannot get up. It's painful, but it's in order to maintain adequate cardiac output so that the patient is not having poor perfusion. So atropine works by blocking the effects of the vagus nerve or blocking the parasympathetic. The dose is 0.5 milligrams rapid IV. You don't want to give it too slow because they can have a reverse action. And you can repeat this every 3 to 5 minutes up to a total of 3 milligrams. We want to be very cautious in patients with myocardial ischemia because those patients who, if you give atropine and it increases the heart rate too much, again, your tachycardia is very dangerous for a patient who has myocardial ischemia because you decrease the diastolic filling time when you're going faster, and it decreases the amount of time the coronary arteries are going to perfuse. Also, smaller doses than 0.5 can also have a reverse effect where it actually will slow the heart rate. So, checkpoint. Gentleman brings his 67-year-old wife into the emergency room. He reports that she collapsed at home while rushing to answer the doorbell. She had no loss of consciousness, but reports having felt weak and dizzy. She's pale and sweaty, blood pressure 72/50. She's placed on the monitor. Okay, let's look at the rhythm. So it's a regular rhythm. I can definitely see that the heart rate's around 40, if not less. So again, is she stable or unstable? If you said she's unstable, you are correct. And she's in a sinus bradycardia because she has P waves. It's less than 60. It's regular. And so what do we need to do? Well, monitor techs, you're going to be notifying the responsible clinician. Nurses, you determine that she's unstable, so you're going to treat this patient with the Brady algorithm according to ACLS guidelines. Now, a sinus arrhythmia, basically looking at the sinus arrhythmia, it's irregular. All that is that the rhythm is irregular. So it's off by 3 boxes or more. So your R to Rs are off by 3 boxes or more. So we would calculate the heart rate by using the 6-second strips. And these patients usually your rates are 60 to 100. They may be bradycardic. The P waves are all upright. They're all the same because it did come from the SA node. So we call it sinus. Your PRI is normal, 0.12 to 0.20. QRS is normal. It's normal where it's 0.10 seconds or less. Your QT is normal where it's less than half the R to R interval. Now the causes of sinus arrhythmia is oftentimes it's a normal thing for respiratory. It's a normal respiratory phenomenon where the rate increases with inspiration and decreases with expiration. So, and it's common finding in your children and young adults. Some people just from 1 second to another, their heart rate changes with movement, with thought, with breathing. So the heart rate can change, and again, that's going to look like a slightly irregular rhythm. Not really significant unless it's bradycardic and they're symptomatic. So the management, again, only if they're symptomatic bradycardia would you have to do any kind of clinical management. This is just an example of a sinus arrhythmia. Again, if you do your R to Rs, they're irregular. So that's what defines as a sinus arrhythmia. Now, a sinus pause. So with the sinus pause, there's two types that we'll be discussing, a sinus arrest and a sinus exit block. And these terms basically are due to a sudden failure of the SA node to initiate a conduct an impulse. So the biggest thing that we really want you to focus on is measuring that pause. So if you have any pause in the red, as you can see, we want to measure the duration of the pause from R to R, and you count the number of small boxes, and then you multiply that by 0.4. So the sinus arrest, the difference between sinus arrest and sinus exit block is your underlying rhythm, in the rhythm on the left here, is regular. And as you can see, they have the R to Rs are going right on time. And then when you have your blocked SA node, and then what happens with the sinus arrest, it comes back, but it doesn't come back on time. If this, as a sinus arrest, it came a little bit earlier, so it did not keep up the same pattern. Whereas a sinus exit block, it's as if you just took away one QRS, and when it came back right on time. So these are missing sinus beats, but a sinus arrest, it just didn't come back on time. Whereas in sinus exit block, it did. Usually the rhythm would be regular, or the base rhythm would be regular, and it can look irregular with the pause. Your rate can be 60 to 100, or oftentimes bradycardic due to the pause. Your P waves are upright, they're the same size and shape, and you do have SA node firing for the rhythm, for the beats that you do have. Your PRI is normal, your QRS is normal, and your QT are normal. But the key thing to remember is measuring the pause. So when you measure a pause, you measure from the R to the R, and you count how many small boxes in between, and you multiply that by 0.04. Same thing, no matter what kind of pause it is, you measure from the R to the R, and you count how many boxes there are. And I believe in the one figure 6.8, this one is 1.32 seconds, and in this one it is 1.64 seconds of a pause. So you count how many boxes and then multiply it by 0.4. So again, sinus arrest, it's a basic rhythm. It's the R to R is regular, then you have this pause, but it doesn't resume on time after the pause. And a sinus exit block, your SA node generates the impulse on time, but it is blocked from being conducted in one or more of the complexes. So top one, this is a sinus arrest. It did not come back on time, and in sinus exit block, it did come back on time. And that's the only difference between these two types of pauses. And again, you would always make sure that you would measure the pause from R to R. So this is how you measure your pause, from R to R, and count how many boxes from this R to this R. And you would report that, and especially if you're having a lot of pauses. So it usually is due to an increase in vagal tone. So if the patient's nauseous or vomiting, or they're bearing down. Also, myocardial ischemia or infarction can also cause sinus arrest or exit block. Hypoxia, and oftentimes medications. So we want to do medication reconciliation to see if they're on any beta blockers or calcium channel blockers or DIG. It usually is not a problem until there's unless it's frequent. So it's really not any significance if the pauses are short or if they're infrequent. It may cause a symptomatic bradycardia, and you would treat that accordingly. And if the pauses are long, you may also have patients will display an escape pacer. So as we've talked about in the first lecture, when your SA node fails, you have at the junction pacemakers may kick in. So you may have a junctional escape beat. Or if your SA node and your junction do not fire, you might have a ventricular escape beat, where somewhere in the ventricles they kick in and you might have an escaped ventricular beat. You'll learn about that when we talk about ventricular rhythms. So the clinical management is a medication reconciliation, so determine if they're on any medications that's causing this, and if the patient is symptomatic, then you would implement the Brady algorithm. So what I'm going to have you do is pause the video and do strips in your book 616, 618, 619, and 620. So for each strip, determine the rhythm, the rate, identify the P wave, the sinus, PRI, QRS, and the QT interval, and then you're going to determine where the origin is, where it initiated the impulse, and identify the name of the rhythm. And we will, when you come back onto it, we'll review all of the strips afterwards. So pause the video and work on that, and then start the video up again. So let's start with 616. So in this rhythm, it is considered regular. So your R to R is regular. The heart rate, so we're going to do the heart rate, and it would be 125. So if you counted how many baby blocks between the R to R, it looks like there's about 12. So I guess this one's a pretty good one to see. So you have 5, and you have 10, and you have about 2. So about 12 beats, 12 baby boxes. So that, if you look in the back of your book, in the small box conversion table for the heart rate, that's going to give you 125. So if you were to use the 6 second, you have 12 R waves in that 6 second. Again, remember, you're only counting how many R waves within that 6 seconds. You do not count P waves or T waves, only R's. So you're only counting all of these R waves in here. All right, let's erase all that. So heart rate is 125. P waves, you do have P waves. They're all upright. They all look the same. We know that this came from our SA node, so we're going to call it sinus. So if we have a P wave and an R wave, we can do a PR interval. So when you're measuring your PR interval, you make a measure from the beginning of the P wave to the beginning of the QRS. So counting how many boxes you have, and it looks like there's about 3.5 boxes. And again, you should count more than just one PR interval and check them all. And you'll have some variation between one complex to another as to how many boxes. One can be up to 1 to 2 boxes difference. And that's okay. So the PR interval is 0.12 to 0.14. Your QRS, again, you measure from the beginning of the QRS to where S wave comes back, and you count how many boxes, and it looks like it's about 2 boxes, some maybe a little bit less. Whoops. So again, from the Q wave to where the S wave comes, and looks like most of them are 1.5 to 2 boxes. So 0.06 to 0.08. And then we're going to do our QT interval. So with the QT, we measure from the beginning of the QRS to where the T comes to the isoelectric line. And again, you can check a couple of them. I'm just trying to show you where it would be measured. So it looks like there's about, your QT is about 0.22 to 0.24. So maybe about 6 boxes or so. So this is a sinus tach. Because your heart rate's greater than 100, you are coming from the SA node, so we are calling it sinus, so sinus tachycardia. And what do you do for sinus tachycardia? you find out the cause of it and treat the cause, or ask the why. Why are they in sinus tach? On 618, this rhythm is considered irregular. So we would use this small, not the small box conversion table, we would use the 6 seconds. So you would count all of the complex between your, okay, so your 6 seconds. So you do not count the first one and you don't count the second one, because we don't count T waves, we only count R waves. So we have 6 complexes in these 6 seconds. And we have P waves, so we know it's coming from the SA node, so we're going to call it sinus. And again, that's part of your interpretation. So, you know, you can put sinus right down in the bottoms. Sinus something, right? So, your PRI, because you do have P's and you have R's, so you can do PRI intervals. So you would measure your PRI, beginning of the P to the beginning of the QRS, and you again would check on a couple of them. And it looks like about 4.5 boxes. So 0.16 to 0.18, your QRS complex, looks like it might be about 2 boxes, some maybe even more. This one looks like about 2.5. So it looks like 2.5 boxes, so that would be 0.08 to 0.10. Still normal. Your QT interval, again, you have a patient that is from the beginning of the QRS to where the T comes to the isoelectric line. You count how many boxes there are, and it looks like there's about 9 to 10 boxes before your QT interval. Beginning of the QRS to the beginning of the T wave. To the end of the T wave. My apologies. Just trying to do 2 things at one time. So your QT interval. Okay, so let's erase all this. So you have a normal, you have a sinus rhythm. The heart rate's in the 60s. It is irregular, so we would call this a sinus arrhythmia. And your treatment, if it was a bradycardia and the patient was symptomatic, you would follow the Brady algorithm. Otherwise, just monitor your patient and do medication reconciliation. All right, 619. 619, that rhythm is regular. So we would be able to use the small box conversion table and we get a heart rate of 79. You do have P's, and so therefore we're going to call that sinus something, right? So let's measure our PR intervals, because you have P's and you have R's you can measure. So you have a measure before the P's, and it looks like it's about 4 to 5 boxes. So we are 0.16 to 0.20. Your QRS, again, you're measuring from the beginning of the QRS. It doesn't have a Q, so we're just going to go from the R. And some of them are smaller than others, but it looks like our QRS is about 0.06. Your QT intervals. Let's erase all the rest of that. So the QT, so you measure from the beginning of the QRS, or the R wave basically, to where the T wave comes in. And you're going to count how many boxes, and it looks like it's about 0.36 to maybe 0.38. So this rhythm is regular. The heart rate's in the 70s or 79. It's sinus, and therefore we would name that normal sinus rhythm. Let's go to 620. So this rhythm, it's regular. So if you were to check the R to R's regularity, it's regular in the beginning and it's regular towards the end. It is just irregular because of this pause. So the intrinsic or the basic rate is regular. So you can figure out what the heart rate is by counting how many boxes between R to R. And again, that would be a basic rate of 88. Now, you have P waves. So before every QRS, you're absent of any kind of complexes in the middle of the pause, but we are going to call it sinus. So your PRI, so with your P's before your QRS's, so we're going to measure the PRIs, okay, not just one, but a couple of them. and it looks like your PRI is about 0.14 to 0.16. Your QRS is about 2 boxes, it looks like, so about 0.08. And a QT interval. So I'm going to erase some of this stuff. So your QT interval would be the beginning of your QRS to the T wave. So it looks like about 0.38, maybe 0.36 to 0.38. So your QT is about 0.36 to 0.38. So when we have an interpretation for this rhythm, we are in sinus, right? We're in normal sinus rhythm because our heart rate is actually 88 as a baseline. So, and we have a pause. So let's take a look at how much that pause is. And if you do the pause and you take and count how many small boxes between the R to R of that pause, it actually comes out to 1.32 seconds. So this pause is 1.32 seconds. The other thing that you may or may not have realized is that there is a U wave. You can just see it. It's very low voltage. And so I would check their electrolytes to see what's going on there. That can be a factor. So there is U waves in there. So then you have to figure out what kind of pause is it? Is it a sinus arrest or a sinus exit block? Well, if you're doing your R to Rs, these are regular. And as you're doing it, you basically come back right on time. So this is a sinus exit block. It's normal sinus rhythm with a sinus exit block. A U wave is present, and you have a pause of 1.32. So that's how you would interpret that rhythm. All right, so here's a bonus question. So looking at this rhythm, what is the important thing to identify in this rhythm? All right, so looking at it, if you haven't figured out, I'm going to go draw an isoelectric line here, pretty much. But what the problem is these STs. You have ST elevation. So if you identified ST elevations, you get a gold star. One of the things that we want to emphasize that if you are a monitor tech, you want to note that and alert the nurse right away. And the nurses are going to have to get a 12-lead EKG and probably call a rapid response, check your patient. But that is due to ST elevation, which they could be having a STEMI. And notify your provider. So you have completed identifying the sinus dysrhythmias of normal sinus rhythm, sinus Brady, sinus tachycardia, sinus arrhythmia, and sinus pause, and learned how to evaluate patients' signs and symptoms of decreased cardiac output and the management and the care of a patient with bradycardia. And this concludes this content for this lecture.